But thank you everybody for joining us today. As you may have just heard, we are recording this seminar and we will make this recording available via the Gilbert Center and the Healthy Aging Society YouTube page after the seminar. So if you do not wish to be in the recording, please do turn your cameras off. And again, welcome. Thank you for attending. This is our second seminar of the 2021-22 Gilbert annual seminar series. I can't quite believe that it's mid-November, but here we are. We're really pleased to be co-sponsoring this seminar with the Department of Health, Aging and Society. This is a series of seminars that we do to create opportunities really for the exchange of ideas and to stimulate discussion amongst researchers, graduate students, undergraduate students, community members, and older adults. So yes, so this year our seminars are exploring the theme critical explorations of care within an aging society. We're ecstatic to have Dr. Laura Funk with us today to present a seminar on unpacking the complexity of public preferences for and beliefs, about dying at home in Canada. So we will, as per is the usual, ask you to keep yourself on mute during the presentation to avoid background noise and confusion. Dr. Funk is going to present for about 45 minutes thereabouts. We're going to try and leave the last little bit of our time slot for a question and answer session. Please do feel free to type your question into the chat box at any time during the presentation. We can read it on your behalf during the question and answer session, or you can unmute yourself during that time and ask Dr. Funk directly. So to introduce our speaker, after it's too much of my voice, Dr. Laura Funk's a professor of sociology and a social gerontologist at the University of Manitoba. Scholarship is quite diverse, but it has explored over the years how paid and unpaid carers for older adults and dying persons engage with broader discourses surrounding age, care, and responsibility. She's currently leading 2 SSHRC-funded projects, including one examining this interface between public policy and people's interpretations of the meaning of dying at home, and another examining implications of unpaid carers' interpretive processes for attempts to mobilize carers in a broad cross-sectoral movement. So please join me in virtually, but very enthusiastically welcoming Dr. Laura Funk.
Thank you for that introduction. I'm just going to share my screen here before we get going and move it over here and do present. Okay, so everyone's seeing just the screen, right? Okay. All right, so yeah, thank you again for that introduction. So today I'm speaking, hold on, one last change, there we go. Today I'm speaking to you from the lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples on Treaty 1 territory and the homeland of the Métis Nation. I also want to acknowledge that although I'm officially on research leave, I'm in solidarity with my University of Manitoba Faculty Association colleagues who are on legal strike since November 2nd. So in the last slide of the presentation, I provide some suggestions for those of you who wish to express their solidarity and help bring that to a successful resolution. Lastly, I'd also like to thank Dr. Jana Klosterman, who provided some feedback to me yesterday on an earlier run-through of this presentation. All right, and I apologize if you hear snoring dogs and other animals. All right, so first I'm actually going to start by just engaging you as an audience to envision a few, 3 specific sort of scenarios. And the first one is to imagine that you're currently dying from an illness and that you only have a few symptoms associated with the disease. You would rate the severity of those symptoms as 1 out of 10, and you have no difficulty coping with them. In the same scenario, family and friends are always available to help care for and support you, and healthcare professionals are also readily available. I'm not going to read all the details in here. So in that specific situation, I'd like you to think about how much you would want to spend your last 2 weeks of life in the following places. I'll list a few, and starting primarily with your own home or the home of a family member or friend, where 1 is not at all and 5 is very much. So think about that option. Think also about maybe your feelings, how you would rate this for an acute or intensive care unit, a hospice or palliative care setting, a nursing home or long-term residential care. And then we have, there's the option of other places as well you might think about. That's my dog. All right. The next scenario is to imagine that you're currently dying from an illness, and in addition, you have several symptoms associated with the disease, including moderate pain, difficulty breathing, some difficulty walking. You would rate the severity of those symptoms as about a 5 out of 10, and you have some difficulty coping with them. In this scenario, family and friends are usually, although not always, available to help care for and support you. Healthcare professionals are not always available. Their availability might be delayed or limited in certain ways. So in this specific situation, think again about how much you would want to spend your last 2 weeks of life at home, in the home of a family member or friend. So again, that's that same scale. And again, consider for this option how you'd rate that for an acute or intensive care unit, a hospice palliative care setting, a nursing home or long-term residential care, and of course there might be another place that you're thinking of. And in our last scenario, imagine you're currently dying from an illness, and in addition you have many symptoms associated with that disease: severe pain, difficulty breathing, limited mobility, etc. You'd rate the severity of symptoms as 10 out of 10 and have a great deal of difficulty coping with them. And also in this scenario, you have no family or friends available to help care or support you. Healthcare professionals are not available to visit. Imagine it might be a rural, remote area, for instance. In this specific situation, how much would you want to spend your last 2 weeks of life in your own home? Again, there's the not at all to very much. And then you can think here again about an acute or intensive care unit, a hospice palliative care setting, hospice or palliative care unit, nursing home or long-term residential care. And there's also the possibility that it might be another place entirely that you're thinking of. All right. Okay, so I'm going to take you back now from that sort of envisioning scenario to talk about the sort of rationale behind our project and some of the key messages that we'll continue to talk about throughout the presentation. So as many of you know, the proportions of home deaths in Canada are still relatively low compared with other industrialized countries, and coupled with cost concerns of governments, there's growing calls to shift this and indeed to position home death as an outcome and quality indicator for healthcare services. And so as well as emphasizing cost savings to systems, these calls are frequently bolstered by talk about evidence of population preferences for dying at home. And in many ways, they align and extend with the dominant discourses around aging in place as well, tying them to the conceptions of the good death. So our team has been concerned that inadvertently some of these dying at home narratives in that policy or public sphere can do several things. One is that they might obscure the contingent and relational nature of end-of-life preferences and processes, obscure cost shifting to families and contribute to guilt, for instance, among family members who can no longer care for someone at home. That they can contribute to sort of an idealization of dying at home with maybe lack of understanding of what might be involved or what that might entail. And potentially also that some of these narratives can obscure inequities shaping people's experiences of dying at home and whether or not we even have a choice, especially for some individuals. So in the news recently, you might have, if this is an area of interest for you, you might have seen this CD Howe report that came out recently, and Andre Picard did sort of a companion editorial, I suppose, around it, entitled "Canadians Aren't Dying as We Wish." And in the CD Howe report, there was an emphasis on Canadians really aren't dying in the place that they want to be, and that the delivery of palliative care needs to be aligned with preferences at the end of life. And then the authors go on to address estimates of how many Canadians could or should die outside of hospital, and repeatedly emphasize the cost savings. And they're doing that to help create that, the emphasis on the need for this to happen, and to convince policymakers as well, especially in comparison to the costs in hospital and acute care settings. And some of you may also know that CIHI, one of their key quality indicators for health systems is death at home / not in hospital. They're going to release some information on this indicator, I believe, next year. But you'll see here again, many Canadians would prefer to receive end-of-life care at home rather than in hospital. So using this as sort of an indication of a higher quality death experience. You have the caveat of when supports are available there. When our group was putting together the grant proposal for this project, we found that Canadian evidence of public preference is actually fairly sparse. We've identified 3 studies. 2 of them are sort of larger sample sizes. So one of these is Donna Wilson's team collected data in 2010 from just over 1,000 Albertans, finding that when they asked them where they wanted to be at home near death, 71%, where they wanted to be towards death, 71% said they'd prefer to be at home. And then the Canadian Hospice Palliative Care Association's national panel survey was done in around 2013. And if I'm reading it correctly, 40% expressed no preference, and of those that did express a preference, 75% preferred home. I believe few actually expected that they could die at home, which was interesting as well, or a fewer percentage. And then there was a much smaller, sort of maybe less rigorous study, but with older retired persons in Quebec City, finding that when faced with the hypothetical scenario involving pain, that there was more likely to choose hospital as a place of death. And now there's at least one other study in Canada with a sample of, again, around 130, 140 hospitalized patients with end-of-life stage conditions. So that's Kelly Stadjahar and Darren Halen's work, where the average preference for home death of those individuals was closer to 54%, with 19% reporting that it did not matter to them. In other Western or European, especially Western and European countries, there's been some population surveys indicating a wide range of variations for preferences for home death. They range from 49 to 70. Some methodological concerns have been raised about some of the evidence, concerns that expectations and preferences are being conflated, and so on. So we were interested in trying to get some more Canadian data on this, and also to unpack some of the complexity that we sort of sensed might be behind some of these statistics as well. So that's our team here, our research team. And the research assistants are listed there, as well as some of our collaborators. And this is the first presentation of some of these findings, and so I won't be able to get in depth into all of them, but hopefully it'll give you a good overview. You'll notice that this study was also done during COVID, so we did end up adapting it to a COVID context. I'll talk about that a bit later, but essentially, as I see it, our goal was to contextualize and really explore some of the complexities around this idea of public preferences for dying at home. And so that entailed a number of sort of analytic questions that I've just jotted down on the left-hand side here. So looking at things like the expectations of dying at home and end-of-life care, and who does it, that might be within Canadian policy documents. So the method there was the critical discourse analysis. What are Canadian public preferences around location of dying, and also about end-of-life care responsibility, and so that was the panel survey was to address that. We did a second panel survey to look at post sort of after the pandemic. Has that shifted preferences, but we're still analyzing those data. We're also interested in how policy, even around this relevant to dying at home, is developed, and what is the role of public opinion. And we were also very interested in experiences of marginalized groups. We were going to do some focus groups, but had to COVID adapt as well. So I ended up talking to sort of stakeholders and advocates, including those working with marginalized populations, to look at some of their understandings around the complexity of social meetings and conditions around dying at home. And some of the stakeholders were also members of the groups that we were interested in looking at. But that's a quick overview of the study. The first piece it was being led by our PhD student Erin Scott, and so this is an in-progress piece that she's been working on. So she's essentially pulled together primarily provincially level policy documents related to dying at home in Canada, and then a discourse analysis of those, identifying this sort of dominant discourse around dying at home as a choice that also benefits the system in terms of cost savings. And the tendency towards universalistic assumptions about home as the best death for all. And this is sort of an extension and confirmation of some other work done by scholars in other countries as well. So we're kind of confirming that within the Canadian context. The cost to and capacities of families is also largely obscured within this sort of policy level rhetoric, especially the issue of gender that might be important to address. The equity of access to services that would make home death a desirable or attainable option also tends to be obscured. And then we also noticed that there were, again, these repeated but often vague claims about most Canadians want to die at home, sometimes citing some of those studies and sometimes not. So we were interested in flagging that as well. Right, moving on. I'll touch briefly on the key informant and policy interviews that we did with, so this was a range of individuals, but folks working in government, health executives, directors, policy analysts. Some of these were themselves clinical nurse specialists involved in say, regional health system governance and so on. We were interested in talking to them about how policy is made. We had some questions about COVID by this time that we had done the interviews. How is it implemented? Those sorts of things. And I'm going to touch though on one particular finding in a minute. So, the issue of, there's policy being developed in palliative care and home care, particularly at the provincial level, other home and community care services, but there's a number of pressures that affect uptake and implementation, which was really the focus of a lot of their talk in the interviews. And that, an acknowledgement for sure of those inequities in people's ability to die at home was expressed by those key informants. And the fact, particularly like palliative home care is not widely available. And that really, if you're going to die at home, you have to have that like committed, capable family caregiver and or private resources. So the finding I want to touch on though, in particular from these data, is the role of public preferences. So I was reviewing the data for that. There was a question around that in particular that we asked, as well as a question, just a general question about how policy is developed. So most of the key informants believe that strong public demand and or grassroots advocacy was an important driver of policy related to dying at home and palliative care. Generally, there was, this belief that most people prefer to die at home, although it was a little less clear, I think, in Quebec. And there was sort of an acknowledgement among key informants that policy generally reflects this dominant public preference, at least in rhetoric, if not funding and implementation. So there was some uncertainty there. But the key informants also said a number of things about that idea of sort of dominant preferences. They tended to see those preferences as largely uninformed about the caregiver role requirement and about the limitations of home care services or palliative services. So they're sort of unrealistic. They did note that, there's other important influences on policy and implementation around a concern about costs and leadership. Key informants also acknowledge that some people do not wish to die at home, less so, or, that should be or, may not even have a choice. And a few of the key informants emphasized the quality of care and death should be the emphasis rather than the proportion of home deaths. So some were in fact directly speaking back to the CHI indicator with those kinds of comments. Emphasis that if home deaths are to happen, we actually need formal services investments. So this idea, I think as one person raised it, it could actually be costly and it involves some costs if we want to provide the services that will make home deaths more possible for more people. And then there was this also a sentiment that policy does tend to ignore issues related to family capacity and burden and the supports that are required. Oops. Yeah. Okay, I'll just flip to the next slide there. So from there, so one of the things we wanted to do as well, as I said, was to assess, sort of get some more data currently on public preferences, and to use this vignette technique that we felt would kind of draw out some of this complexity in a survey form. And so those vignettes that you were asked to consider at the beginning of the presentation, we used those vignettes in the survey, which was done in French and English language. And again, our goal was to address this gap in some of the survey data and to, we designed this as a mixed method study, which we're just getting to sort of now do that comparison and juxtaposition with some of our qualitative data. So this was an online panel that was with 2,500 from general adult population respondents. So the caveat there is it's not purely random. Also this particular time one, we're calling it, was done pre-COVID. So even though it was not a purely random survey, we were able to pay for certain quotas to achieve some representativeness around age, French as first language, and rural geographic region. And the resulting sample was also about 49% female and 81% identify as white. The analyses that we're going to present today are within subject repeated measures of analyses of variance, so ANOVAs. We're looking at those three scenarios that I presented earlier are sort of the mild, what we're calling mild, moderate, and severe situations or scenarios. And so we looked at how people would rank those different locations of dying in each of those situations. But in particular, the findings we'll talk about looked at moderators such as a measure that we had of support for family obligation, sort of norms, and then age, which we looked at three groups, classified into three groups. So this is an in progress paper, hopefully soon to be submitted. So the key findings from the survey were that as the severity of that situation increased, remember that it's not just severity of the symptoms, it's the severity in terms of the lack of formal and informal supports. So as severity of the vignette increased, preference for dying at home decreased, whereas preferences for dying in these other settings, most notably palliative care, but also to some extent long-term care and even in an ICU, increased. And for the respondents who had sort of high family obligation scores, home dying remains the preferred option even in that most severe scenario. Whereas for those respondents with sort of what we'd call low adherence to family obligation norms, both the ICU and especially palliative care units and hospice were preferred in that most severe situation. And for older adults, preferences for palliative care unit or hospice approach those of homes, were similar to those of home in the moderate vignette or moderate situation, and then surpass it a lot more in the severe scenario or situation. So that meant that older adults in that oldest cohort even preferred dying in ICUs over home in the severe situation. And then there's a couple of visuals for those of you that prefer something a little more visual. The legend is a little hard to see here. Home is actually the column that is sort of stripy. ICU is sort of a medium gray color. Palliative is the white. And then long-term residential care here is the darker gray. And this breaks it down by preferences in each of those scenarios. This is between for the high family obligation folks and low family obligation folks. And notably, even those expressing strong support for family obligations tended to have reduced support for home death in that severe vignette. In fact, it's similar here. And there's the same for younger and the older adults. Okay, oh, and I will mention that one of the things we think might be happening with the age piece is it could be either a cohort and or an age effect of maybe increased preference for medical intervention, under maybe certain understandings of palliative care, maybe an increased desire to place trust in medical professionals that may be age or cohort related. Great. Now we're going to shift from the quantitative to the qualitative, so that will help us unpack some of the more complex social meanings and conditions involved here around dying at home. So we had done 24 stakeholder interviews with participants who had frequent interaction with marginalized or diverse subgroups. Maybe they acted as a group advocate for these groups or that were themselves a member of the group as well. These groups were theoretically sampled based on what the existing literature suggested might be a source of variation related to preferences or abilities to die at home. So that could include bereaved family carers, French Canadians, members of Two-Spirit LGBTQ plus communities, those living in rural and remote areas, structurally vulnerable populations, so sort of homeless, precariously housed individuals, immigrant communities was another interest. We also interviewed several representatives of what we'd call a compassionate communities movement, and then just incidentally, we found several participants also have identified as Indigenous as well. And the reason I'm not providing that in a table form is because many people identified and crossed multiple social locations, so it's really hard to represent in a clean tabular form. So you might have a bereaved carer who is now a service provider working with a structurally vulnerable population, for instance. So we sort of adapted our interviews to address their sort of multiple locations. We asked them about their own personal beliefs and sort of interpretations of the meaning of dying at home, and then asked them about how would this sort of play out in the groups that you work with and are familiar with working with. All right. Oops. I'm going to present some of the key findings first. Obviously, when we ask people just, in a qualitative way, where would you want to die, the most common sort of initial response is sort of where I don't want to die, and often that kind of institutional environment, right? So it's defined against the sort of unwanted alternative of institutional care and what the person associates with institutional care. But as we went on to talk to them further about what does it mean to die at home, what is the meaning of home, the meaning of home itself is much more fluid, relational, and often non-place based even. And we really saw sort of a lot of what I'd say sort of an expanded definition of home that we're going to look at a bit more, but it's interesting because, does this expansion of the meaning of home represent sort of an acknowledgement of participants' acknowledgements of the constraints on choice around place of death, or attempts to sort of make positive meanings of situations where home death is not possible? So a number of different things might be going on there. We did also find that few straightforwardly idealized dying at home, though there was variation, but many instead emphasized contingency, nuance, sort of pragmatism and adaptability, the sort of it depends response. And people's own social locations and life histories and previous experiences shaped the meanings of dying at home, as well as of family, of home. There's a lot of complex concepts here. Participants were also highly aware of structural barriers, if not influencing their own situation, but that would influence, for instance, marginalized populations. They were also highly aware of impacts on family, and I'll touch on that again soon. And for some participants, particularly professionals that worked in palliative care, some of them had an awareness that good care can be provided, especially in a palliative care unit or hospice situation. And that's another piece here, was that the meaning of dying at home really encompasses what happens after death, something that really we hadn't thought of much going into the study. how one was treated, I think, emerged as the dominant concern. Are you treated with sort of, you have autonomy? Are you treated with sort of, is your identity respected, and so on? And so we'll talk about that going forward. So just in relation to the comment around their acknowledgement of structural barriers, this was identified as shaping people's preferences and decision making, but even beyond that, just like whether or not they even have a choice, and maybe we shouldn't even be having this conversation around preferences. It just didn't feel right or seem to fit well in some situations and circumstances, especially when dying well at home may not be attainable for many. So you might have a certain kind of condition or dementia, for instance, or you might have poor access to publicly funded help or to family caregivers. You don't have financial resources, you don't have stable housing. So an example there being precariously housed individuals who are receiving services in some kind of setting, for instance, for those who are using addictive substances and so on. And in some of those situations, they're deemed an unsafe environment that home care nurses aren't allowed to go into. That would be an example. So one of those workers, for instance, talked about how our system makes a lot of assumptions about what people have access to at home and whatever that home might look like. And then many of the participants themselves acknowledge their own relative sense of control and privilege when answering questions around, well, where would you want to die? Well, I'd want to die at home, and I have the ability to make sure that happens because I can save up and so on for private care. And then the next few themes I'll touch on just briefly are themes that we identified as things that sort of their meanings associated with dying at home, and dying at home is seen as facilitating these sorts of concepts, if you will. So one of those is probably one of the main ones is social integration. So there's this idea that dying at home reflects and reinforces social integration and relational connection to others. And that's not just family, but also communities as well. COVID, of course, is complicating this, which participants talked a little bit about, but I won't get into that. And this is juxtaposed again against neglect and isolation, especially the idea of older adults coming up in this sort of talk as well, and that dying at home is sort of symbolic of being surrounded by those you love, that love you, and have a sense of belonging, and that it can prompt mutual aid within communities. So dying at home logistically was seen as providing this sort of facilitating social integration and community integration, but also helping you better integrate into just the everyday life of for instance, your family and things that they're going about doing. And then there's a symbolic aspect to it as well. And then there's always nuance and exceptions, though. So these were just a few examples of sort of, in some cases where, for instance, this is a transgender participant referring to how some members of the community might feel that their homes are already somewhat of a prison because they can't really, just because they're not safe enough in an institutional environment, and because of broader stigmas and marginalization. And a few participants talked about how institutional settings, if they can accommodate visitors, can actually, for some isolated individuals, increase their interaction to and sort of within the healthcare workers coming and going kind of idea. And then as an added nuance, we spoke to one individual from an immigrant community who has had much experience helping facilitate the return of some individuals home to their country of origin because those people didn't have a lot of family currently, for instance, in Winnipeg, and so they wanted to return to have that embeddedness within the family and community just before and after death, even having people coming to visit the grave. Reclamation also was identified as sort of something that dying at home was often associated with and is seen as facilitating. And this was often in the sense of dying at home as helping us return to I've got that caveat here, around sometimes an idealized past, but this idea that it overlaps with social integration, but also we can think here about these other ideas that were raised by participants around demedicalizing death, decommodifying death and funerals, sort of informalizing things, making it simpler, more natural. It's probably not surprising that this emerged, especially among compassionate community advocates. But these kinds of ideas that, it'll help us retain community, our sense of community and mutual aid, and connecting again even to the idea of intergenerational living with older adults. So that's one example there. There was some tension in these in this theme, I suppose, around recognition of the importance of professional supports and expertise versus positioning dying at home and care for someone who's dying at home as so simple that anyone can do it. And so that was interesting as well. And then we have the ways in which dying at home might be seen as helping folks preserve a sense of selfhood. And in the most sort of extreme example, we think of protecting oneself from harm that you could incur in an institutionalized setting. So that came out, for instance, among LGBTQ participants, speaking about why you might feel the need to, or you have to stay home in order to protect yourself from those harms of institutional settings and that can be inflicted on you and your identity. More broadly among participants, just the more general idea of preserving your selfhood, that this could be more possible if you were to remain at home, again, often influenced by your perceptions of and experiences with previous institutional settings. So people talked here about being able to have something familiar, something that is theirs around them at end of life. So this could be things that connect you to who you are and your identity. And perhaps this importance of being in familiar surroundings might be especially salient. I think someone pointed this out in a context in which people themselves are not very familiar with death and dying itself. So here we could think about the familiar people around you. So that integration is also tying in here, but also people's relation, their identity and its relation to things around them and to physical spaces would also fall under this theme. And that the way in which we want to preserve our selfhood might in fact be more important than a specific physical space. For some people, their sense of self was more tied to a physical space, but for someone who moved around a lot in life, it may have, for instance, less salience. All right. And then the final piece here was around how dying at home was envisioned as helping someone maintain control sort of over their everyday life and personalizing that end-of-life care, especially in a context in which you don't have control over what's happening to your body. And so that would be an example here. I've got a star here, which I'll return to in a minute. The idea that dying at home can get you some semblance of freedom from unwanted interference and intrusion, invasions of your privacy that might happen in an institutional environment. I do sense that choice of the actual location and circumstances of death was more important for some than others. So some framed it more as control over these everyday things. For others, the actual location and how they died was more important. So some would even connect this to not just dying at home, but to MAID, and that also helped them get that sense of control over the exact circumstances and nature of the death. And especially for the compassionate community advocates, this idea of control extends to community control of dying. If we have more dying at home, the community can regain control of that process. And then my flag there was that we have to juxtapose this idea of control about the fact that many people also acknowledge that there's a lack of control for many people, even around where they die, and as well as the lack of control that they've had maybe throughout their life course as well. So then, as well as talking about and identifying those sorts of themes in their talk, participants also were stuck in that dilemma of, well, how do I, even if I want to die at home, how do I protect others? Especially if the family are not seen as able to cope, or if care circumstances might entail particular burdens. And so we've seen a relational understanding of death and dying that underpins, participants talk about social integration of dying persons earlier, or that might have a relational sense of identity that they could preserve through remaining at home. But this relational understanding also really comes out here in this idea of their emphasis on wanting to care for and protect family members. And so when they talked about dying at home in relation to family caregivers, it was seen as a lot less positive, right? So isolation, fear, risk, burden, those sorts of things, changed feelings towards the home space came up as concerns. So that could be they were aware of the burden of care that might be entailed, or that even just having to make decisions, or experiencing guilt, witnessing. Some people refer to, especially if it was a more what was defined as a more traumatic kind of death, or that there might be difficult memories associated with the home space. There were just a few exceptions of people that spoke of benefits for family, and I'll present one on the next page. And then one participant did sort of say, well, this idea of not wanting to be a burden is more individualistic, and it's, you know, we need a culture that prioritizes interdependence and rather than independence and not burdening. But within the sort of cultural frame, I guess, if you will, of sort of individualistic society in which we are concerned about our effects on others and impacts on that when it comes to care, it's possible that not expressing a strong preference for location of dying or being open to dying in institutional settings might tie into concern with protecting family and that relational concern, as well as a connection to perhaps caring identities of participants. And some participants even frame this idea of saving financial resources to help, that's part of what you're doing to help protect your family, because they don't have to do as much if you can hire additional help. Or even, I think there was at least one or two participants that mentioned MAID as one of these against kind of a relational strategy to mitigate the burden on family. And this is the contrasting, but still a relational example, focusing more. This was an LGBTQ participant that was a younger participant with no partner, who said they didn't have a strong place attachment, but when asked where they would want to die, said, well, I would go back to where my family lives. It was a different geographic area. They said, for their family, being together is very important, and this is her framing of it in a relational sense, that dying is partially about who's dying and also largely about the people around you. I would want to be close to those people, so I would do that to try and make it as easy as possible for them. The people who are in my family would have some closure, and it would maybe make it easier for everyone to do their thing. And then this is that. So it's framing that move back to where most of their family is as an act of service to their family. So giving them the ability to grieve at home. And then I have a few concluding points. The first one, I am thinking a little bit here because I know there's also a interest at the clinical level in ascertaining sort of particular patients' preferences at end of life. And we do think we need, one of the sort of outcomes of our findings is that we believe you need to develop clinical supports that are responsive to those changing contexts, but also to have those, as clinicians, to have educations and conversations about end of life as a process rather than a distinct event, and to acknowledge that it could occur across multiple care locations. And then, while we know that it's great to have sort of aspirational goals to promote and facilitate, help more people die at home, if that's important, and it requires investments in palliative home care, we do have to make sure that, do these policies represent evidence that we know of variation and contingency, and are there ways to nuance how dying at home is presented, as well as how preferences for dying at home are presented in policy and in public arenas? Is there a way to develop more nuanced public policy and health system quality indicators? We know that end of life and care trajectories and realities are much more complex than the idea of choice would imply, and preferences often implies choice. I think the other challenge here is that choice then also might imply responsibility then for the outcomes of those choices, that then directs attention away from structural barriers to a good death at home. We need to have policies and conversations that represent and hopefully address the gendered realities of unpaid care. And continued investments, we need to have continued investments in both institutional and home-based services. Reading through those different themes of the stakeholders really, brought forward the importance of how can we make humanistic relational care more possible within the institutional settings. and then even beyond, I think sometimes that palliative home care is presented as sort of a, its way to address, facilitate home dying and home death. And we need to address structural barriers for those at the end of life, but we also need to think about this more broadly to look at social justice and social inequalities that people face across their lives, even prior to end of life. I think that is my last point. The one thing too that I wanted to highlight is that we do have these time 2 survey data that we're analyzing. We're interested in whether COVID will affect people's preferences from the same sort of vignettes, knowing that with the visitation restrictions and so on in institutional settings. And Richards and Rowley in the UK recently proposed that the pandemic was changing the public narrative that home was best for dying to a more unfavorable thing, because it was driven, you could see it being so largely driven by a fear of being in the institutional settings, and also that when you were with dying at home, often during COVID has entailed a lack of those sometimes both formal and informal supports. So it sort of counters that idealism that was normally associated more with home dying. There we go. Okay. So I have references on the final couple slides too, or you can contact me for references. And this is my final plug for the UMFA piece, which I'll leave up here as well. That's me wrapped up.
Great. Thank you so very much, Laura, for the presentation and for sharing, I think, what's really important and really needed work. I know this term I'm teaching a course on death and dying in later life, and what we keep kind of butting up against, I suppose, is the lack of, especially Canadian focused data. So I'm personally very excited, and I know I probably that excitement is shared across the audience here. So thank you so much for taking the time to be with us and share with us today. I would invite anyone who has a query for Laura to either pop that in the chat box, or if you would like to share your voice, I'd love to hear your voice. You can just pop your hand up, and then we can ask you to share your question in that way. Maybe while folks are taking the time to dream up a question, Laura, I wondered, I'm really interested in new and creative ways to elicit responses or experiences from people, especially about potentially quite sensitive topics such as death at home. I'm wondering if I could get you to speak a little bit more about the vignettes. I'm quite intrigued by them. How did you kind of come up with those? Did you have to test them out, or can you just chat a little bit about the vignettes?
Yeah. So the whole survey itself took about a year to prepare. The vignettes were a key part of that. I think we had consulted with somebody, a psychologist who did vignette surveys specifically. We had felt that would be a much better way to tease out some of the variation. The development of them took quite a long time. It was informed, but we did go into it, kind of the literature does say that this availability of formal and informal supports is important and will affect preferences, and that also the symptoms will as well. And so it was those three things we went into to kind of, let's look at some vignettes that maybe mix those up a little bit. We weren't able to, in the end, because we didn't want to ask more than 3 vignettes. We didn't mix it up to every possible combination. So we just have, I suppose we can't in the end disentangle, which of those was more important, right, in people's determinations. But yeah, we just, I don't know, it was a collaborative process in our group just to come up with the vignettes, really. And then we did test them on several and just people we could find for sort of face validity, and then just repeated back and forth. And we had to, the whole thing eventually was translated and back translated from French, but. Oh, sorry, you're on mute.
Let's put myself not on mute. There we go. Quite an iterative process, it sounds like. Oh, fantastic. Jana, feel free to unmute yourself and ask your question.
Nicole, you might need your "I'm not on mute" or "You're on mute" t-shirt.
I was thinking.
Yeah, I've had a bit of a chance to preview your talk, so I've had time to think about it the last day, but I did wonder if there are any invitations for kind of rethinking that role of family care provider, or because I found it really interesting that your participants themselves were kind of critical of those idealized ways that maybe, or idea that you can care against all odds or against any conditions, or they were really showing how context matters. And on that note, I also just thought there were such cool overlaps with Nicole's work that indexes the forms of work and uses that as a way in to look at how it's organized, or how how care works. So I wondered, with that role in particular of family care provider, how does this help contribute to a rethinking of it?
Yeah, I think I would say that where we saw the most acknowledgement of, well, it's interesting that everyone acknowledged that it would be difficult for family caregivers, and especially these many of these were bereaved former caregivers themselves who had helped someone die at home, or so they've seen this. And then many were also palliative care professionals, so they've seen a lot, and so they would refer to situations where we've seen this kind of, like, it can work, but it can also not work well, and we've seen people troubled with through their bereavement, because this person didn't die at home, or that was like a particular issue that came up, right? So they're drawing on their own experiences, I think, to inform that. So it may be a reflection of the sample in some ways, and among participants who are a little more likely to idealize dying at home, I think they were a little more evasive of this issue of, well, when it comes down to it, who's doing this work? In a compassionate care advocates, for instance, that would fall to communities as well to sort of help support the family. But I remember one respondent saying, even like, the community can't actually provide the care, so we can like help and come around and do certain things, but I don't think we could actually get right in there and do hands-on. So I think it would just be nice to see the discourse around this continue to acknowledge that impact on the family caregivers, but also how much it's nice to see the participants themselves acknowledge, like, how much would I ask my family to do, right? And what would they be comfortable with? And I need to have that conversation with them, and maybe they really want to do it. Like someone emphasized, I should have asked my partner, because when I ended up asking them, they said, actually, how could you assume that I wouldn't want to be involved, right? So that's some of the nuances around that. But how can we make sure that families still feel they are supported, right, through that process? That when home care services are more limited, even more will fall to the families as well. But it would be great. Our participants didn't really acknowledge the gendered part of it, but it would be nice to see some of that embedded in policies and public discourse as well. I don't know if that answered your question.
Okay. Yeah, well put. And I'll be waiting for the Funk Dahmer follow-up piece. The aging in place, dying at home collaboration.
It will get right on that. Or I was just thinking
probably this week.
I was thinking too, Laura, I was thinking about that piece in the conversation with Julia Brasilato and I think Sally Chivers and another colleague about the emergence of death-friendly communities. And I was thinking so much about how your research will have so much to speak to that, I think, as well, as it's kind of an emerging kind of concept to think through.
I'll follow. I didn't read that particular piece, but one of the things with it's maybe getting more into the compassionate communities issue, but we did have a student who ended up volunteering with us for the summer and was inspired after reading some of our interviews. It wasn't that our participants talked about gender, but he was just interested in the lack of that piece around, especially the compassionate communities. So we ended up writing a blog post. Oh, I wish I could have had the link offhand, but for the Glasgow End of Life Studies group on who is doing the work in compassionate communities, right? And often the unpaid work. And so I think that's it's what would be the word? The blog post has provoked some conversation, let's say.
I've been reading too, there's The Order of the Good Death. I'm not sure if you're familiar with that too, and they've recently been having some kind of blog post as well, kind of with a feminist lens on death care. So I think it's really an interesting and kind of fascinating and timely angle to be examining. I've received a question in the chat from Stephanie Hatzi-Fililithis, a PhD student in our department. She just says, thank you so much for an insightful and engaging talk. And then she says, you mentioned that as severity in illness increased, preference for dying at home decreased. Did participants elaborate on this, or do you have any thoughts about why this might be the case? And then kind of as a second question, did the kind of expansion of meaning of home, as you'd called it, decline, or the inability of being able to die at home increase?
Right, so I'm thinking with the survey, it was as the severity of the situation, not just the illness or the symptoms. So it was the severity of the situation overall. So in that scenario in which you had not just high symptom severity, but also not a lot of formal and informal support, then people's preferences for dying at home were less, largely again because you might be more likely to want to be in a situation that had more security for you, right, and access to help. So we don't have sort of follow up about why they said a particular answer, I suppose, for the survey. And sorry, the second question was more around, I think, from the qualitative piece around the expanded, very fluid definition of home, right?
Yeah.
So we don't have that as connected as much to well, we do. We have people talking about, well, it would my preference to die at home, but for me, dying at home includes like spending as much time as possible, but then it could include dying in a hospital at the very end, or my mother died in long-term residential care, and that was her home. Right, and so that kind of flexible, or home is a feeling and home is what you create, and it's almost like a sense of maybe adapting to the structural circumstances, right, adapting kind of cultural meanings and so on to be able to accommodate that the structural realities, really, right? I don't know if that answered it properly. Was there another question in there that I missed?
I think you covered it all, and I'm seeing a thumbs up from Stephanie on Zoom. So I'm just taking a look at the time, and we're very nearly at our 3:30. I'm wondering if anyone has a rapid fire question, a last question they'd like to pose to Laura. Hearing or seeing none at this moment, I imagine Laura would be open to receiving, for example, a question later on, perhaps over email.
Yeah, I didn't put my email. Can I set it in the chat, my email?
That would be perfect. Yes, thank you.
Okay.
Perfect. So Laura has kindly provided her email in the chat box. And Laura, just wanted to thank you again so very much for being with us today and for sharing your important work. And thank you to everyone here for attending another Gilbrea seminar series in collaboration with the Health, Aging and Society Department as well. And if I may put in a plug for what feels like distant future, our next Gilbrea seminar series is being led by Dr. Jana Klosterman, who we have heard from today with a fantastic question. And she'll be talking about the limits of care, how women negotiate moral, gendered responsibilities in our aging society. And that's February 1st of 2022. And I think that's it for us here. If everyone could join me again in thanking Dr. Funk again, and wishing you all a fantastic remainder of your week. Take good care, everyone.